So I'm going to talk about use of an enzyme called collagenase to treat something called Dupuytren's contracture. So just a brief overview, we'll talk a little bit about the problem of what Dupuytren's contracture is, some of the history of Dupuytren's, traditional treatments, and then a new treatment called collagenase, which is an enzyme that could be injected directly into the cords to avoid surgery for these patients. And we'll discuss a couple case examples and show some video. So Dupuytren's disease, it's a funny name. It comes from a gentleman by the name of Guillaume Dupuytren, who you see on the slide in front of you. He was a famous Parisian surgeon in the 1800s who extensively published and lectured on the problem of Dupuytren's disease. So what Dupuytren's disease is, it's an abnormal thickening of the tissue below the palm, the fascia, which involves nodules and cords which can thicken. Even before Guillaume Dupuytren, other doctors recognized this problem and attempted to treat it surgically by excising these cords. So Dupuytren's disease is a painless problem. It's a benign thickening of the fascia, again, below the palm, and it's mediated by cells called myofibroblasts. And these cells form abnormal tissue, nodules and cords, which early on are not a problem, but with time they can contract and cause the fingers to flex down into the palm, so patients lose the ability to move the fingers. So Dupuytren's disease is when you have the nodules or cords, and Dupuytren's contracture is when the fingers actually become contracted. So it can be anywhere on the hand, but it primarily affects the MCP joints or the PIP joints of the fingers. That's where the contraction occurs. So this has also been called Viking's disease. When I did some of my training in Minnesota and we had a lot of people of Scandinavian descent, I saw a lot of this. It has an autosomal dominant inheritance. Prevalence ranges anywhere from less than 1% to 42%, depending again on the groups. Much more common in people of Northern European descent, Scandinavians, British, Northern German descent, and much more common in men and people over the age of 40. So some of the basic science, basically, not to bore you, but it's an imbalance in the production of collagen, which is a protein in the palm, versus the degradation of collagen. And you develop these firm nodules and cords in the palmar fascia. Eventually, the nodules can grow and turn into cords, which, as you can see in the picture on the slide, will bring the finger down into the palm and restrict the ability to open up the hand. So mild cases, the picture on the top, that's a typical nodule. It's painless, doesn't cause problems. Patients will notice it, but it doesn't cause any functional problems. The progression of the picture on the top to the picture on the bottom is very unpredictable, however. And we don't know what causes the progression, who is more at risk for it, and there are a number of factors that have been studied, including smoking tobacco, alcohol use, trauma, but still to this day we don't know exactly what sets off or triggers that contracture. But when the cords do eventually form and contract the fingers, it causes significant problems. People will say they can't put their hand in their pocket, shake hands, put gloves on, do manual tasks. They can become painful, and cosmetically often patients are bothered by them. So this new treatment has changed the indications that we have, but the traditional indications to treat Dupuytren's contracture, once it's developed an actual contracture in the hand, we have something called the tabletop test, which you see illustrated on the slide. When a patient cannot straighten their hand on a table, that typically it creates enough of a impairment that patients may want to consider having treatment. So traditionally, patients with a positive tabletop test, patients where the MCP knuckle is contracted more than 30 degrees, or any functional problem with PIP contractures. So the good old traditional treatment is a surgical release. There's another option for a percutaneous needle release, and now today we're using an injectable enzyme called collagenase, which I'll talk about. So the good old treatment, it worked very well for hundreds of years. You can have an excellent result. And I tell patients that this is still the only treatment to date which can remove all visible signs of the Dupuytren's nodules and cords, because all of this tissue will be excised. It's time tested. The problems with surgery for this disease is that there are obviously post-operative wound care and problems which can develop. Often we need to use skin grafts, where we have to take skin from another part in the arm or the thigh to cover up a defect. There's a much longer recovery of post-operative rehab and physical therapy, and complications have been reported in about 40% of these cases, usually minor. But today, now we can treat this problem with an injectable enzyme. So collagenase is an enzyme that breaks down collagen. And this is an enzyme that's been isolated from bacteria about 15 years ago. It's called collagenase Clostridium histolyticum, or CCH. And it's been marketed commercially under the trade name Xiaflex, but in the early 2000s, there were a series of studies which have investigated the use of this enzyme to treat Dupuytren's contracture, and now it's been FDA approved since 2009. So basically, the way it works is we take a small amount of this enzyme, we inject it directly into the cords and nodules. Over 24 hours, it gradually breaks down or digests these nodules and cords, and then the cords soften up. The next day in the office, we gently stretch out the joints, and often you can feel a pop or the joint will stretch out often to full extension, and it's safely performed in the office so we can avoid the operating room. Collagenase, there have been over 7 different subtypes of this enzyme isolated, and basically the enzyme attacks different parts of the collagen three-dimensional structure to break it down and dissolve it so that we don't have these tight cords and nodules in the hand. So the particular enzyme that's used, Xiaflex, to treat Dupuytren's, it's a combination of two of these enzymes, and it attacks 2 areas of the collagen structure. The 2 enzymes are called OX1 and OX2, but they work synergistically to break down, soften up the cords, and improve elasticity of the cords so that we can stretch out the fingers and get the fingers straight. And the nice thing about these enzymes, now that we've studied them for some time, we know that they preferentially break down the cords and not the tissues in the blood vessels or the nerves that are surrounding, so it's very safe. So the initial study that looked at Xiaflex was a study published in the New England Journal by a hand surgeon by the name of Larry Hurst. I recently gave a talk with Larry Hurst earlier this week, and it was interesting to ask him about the evolution of this treatment. But this was initially a prospective randomized double-blinded placebo study that looked at over 300 patients and found that 64% of patients who received this enzyme got within 5 degrees of full extension, so basically a completely straight hand. And overall, there was about a 40-degree improvement in the range of motion of the fingers. So here's just a little diagram that shows that on the A side, the results are a little bit better for the MCP joint. So this is where patients started out at about a 48-degree contracture, and they went to almost completely straight, 7-degree contracture. On the B side, you can see the knuckle just past that, the PIP joint. These patients started on an average of about a 55-degree contracture and improved to 22 degrees, but often this joint will not get completely straight just because the joint itself gets very tight. So there have been a number of follow-up studies. The Cord 2 study was conducted in Australia, found the same exact results, excellent results, and was very safe. There was a follow-up study recently published this year in both Australia and Europe, another randomized placebo-controlled study that showed, again, success in about 60% of patients getting close to full extension, and even those that didn't get full extension had significant improvement. And again, this showed that results are better in the MCP joint compared to the PIP joint, but both were quite successful. And this was the first study to suggest that maybe treatment earlier in the course of the disease can prevent the disease from getting to a point where we can't treat it as effectively. So there's some suggestion now that we should be identifying patients who have mild contractures. They're much more easy to treat than severe contractures. So these initial first 2 studies, the Cord 1 and Cord 2 trials, were combined, approved by the FDA, and were found to be very effective. There were a number of minor side effects that are quite common, and basically these are swelling, bruising, pain. Those all go away after a few days. Some patients, about 13%, will develop a skin tear as we're manipulating the joint. That's a minor complication. After a dressing of about 5 or 6 days, that will heal. And then there were a few rare side effects that we've now learned how to avoid from some evolution in the injection techniques, but the one feared complication is flexor tendon ruptures, and fortunately the incidence has been far lower than 0.1% now in the more recent studies. So this is just a little illustration. This hand Over here is an example of one of our patients that developed quite a bit of bruising and swelling. This is a day after the injection, but it completely resolved. This is an example of a skin tear. Again, it's not really a big problem, will quickly heal with a dressing, and this is one of the rare flexor tendon ruptures that was reported early in the literature, but fortunately now we've learned how to avoid these. So there's still no cure for Dupuytren's contracture. Whether it's treated with surgery or injection, they can come back. But fortunately, with the injection, you can receive repeated injections and have an excellent result, whereas with surgery, the results of subsequent treatments are a little more dicey and less predictable. So what are the indications? Now, with the injection, we don't care if someone has a 30-degree contracture. Any cord that's palpable that causes problems can be treated safely and effectively. So now we're able to treat a lot more patients with this problem. Here's a video outlining the technique. There's a patient with a palpable cord. Here I am aspirating some of the enzyme. We clean up the hand. This is done on the first office setting. So 3 areas of the hand are injected. It's a little bit of a pinch. It doesn't hurt me at all. And the enzyme slowly goes into the cords, and from the first minute that we're injecting these cords, it's slowly dissolving the actual collagen in these thickened cords. And then we give the patient about 24 hours for this to slowly break down the cord. And this, the portion of the injection is broken down into 3 separate aliquots, and that's how we found the results are most successful, and we can avoid things like flexor tendon problems. So bulky dressing is applied the same day. We basically ask patients they can go home. It's not very painful, but we ask them not to do heavy-duty activities like gripping, sports. They elevate their hand for a little bit, and then they'll come back into the office the following day. So here's an example of this patient the next day. The cord is softened up, and I've anesthetized this patient with a little numbing medicine, and as we stretch the hand, you can see a pop right there. So that takes place, that substitutes for the big surgery that we used to do. So here's another patient with pretty severe contracture in the small finger, primarily affecting the MCP joint. So again, in the office, we break down the injection into a couple different spots. It starts to work right away. And the ideal spots are sort of the areas where the cord is furthest away from the tendon. So we now know exactly where to inject this enzyme. So again, a dressing's placed. The patient's asked to go home the same day. We make an appointment to have them come into the office the following day. This is an example of some mild swelling, and you can see here as we stretch the finger out, the cord's popping little by little sort of rupturing of the cord. And this was another patient who had an excellent result. He had a hand a few days later that was completely straight. And they can use the hands right away. It's a little bit of swelling which goes away quickly. So patients are treated in a splint for up to 4 months, but I usually tell patients if you can wear it for a month, it will improve your result. And the splint will help fingers get a little bit more straight, because often right after the injection they're not completely extended. And a physical therapist will help us with this, or a hand therapist. So we've adapted a new technique for PIP joint contractures, which initially were not as effectively treated with the enzyme, but now we've gotten about another 20 degrees of extension with the use of a daytime splint for that particular joint. Here are just a few case examples. This is a patient that had a 45-degree contracture, as you can see on the before slide. This is actually this is a day after the injection, so the finger has started to straighten out a little bit by itself. In the picture, it's only about a 30-degree contracture by that point. But they've developed complete extension, a few days later. You can see there's a little dimpling in the skin, and I tell patients the injection will not remove all visible signs necessarily of the nodules. This is the patient we saw in the video, so as you can see on the before and after, and the after results, he basically developed a completely straight finger. This is a patient that had a severe contracture. If you look at the middle finger on the before slide, it was an 80-degree contracture at the MCP joint, 65 degrees at the PIP joint. This is a patient who eventually needed 2 injections. You can do up to 3, and as you can see on the before, severely contracted joint, and on the after, this middle finger basically was completely straight. So she was thrilled with her result, and she was a sicker patient who wanted to avoid surgery. Here's another example of involvement of both the MCP and PIP joints with contracture in both, and as you can see in the after, he got a nice result, but had a little bit of a residual PIP joint contracture, because again, we can't always get them completely straight at that joint, but again, often we do. Here's a patient with an isolated PIP joint contracture, pretty severe, 52 degrees, and he developed a finger which developed full extension. He had an excellent result, and he was thrilled with it. So in summary, there are good operative and non-operative measures to treat Dupuytren's contractures when they affect people's lives, and now injectable collagenase or Xiaflex has changed the way we treat this disease. And I predict in 5 or 10 years where very few hand surgeons will do surgery for Dupuytren's. This will be a non-operative problem, much like other problems like clubfoot and other diseases in orthopedics have evolved. And this is a non-operative based treatment. It involves 2 short office visits, a splint, there's less rehab, no surgical complications, and no skin grafting. So it's been an excellent advance. Although there's still no cure for Dupuytren's disease, this injection can be given if the contracture occurs years later. So it's been a great way to treat this problem. Thank you.